Hello, everybody, and welcome back. My name is Annette Rosenberg, and I'm the founder and president of the Swedish non-profit patient organization, HS International Sweden. So, of course, you understand I'm Swedish. I'm really happy to be a part of Spotlight HS this year, and that is now going global, and other countries are also involved in presentations and things. I have the pleasure of introducing and moderating today's session on current treatments with Dr. Raed Alhusayen and Stephanie Goldberg. Dr. Alhusayen is past president of the Canadian Hidradenitis Suppurativa Foundation. Clinician instigator and assistant professor in the Division of Dermatology at the University of Toronto. Associate Scientist for Evaluative Clinical Science at Odette Cancer Research Program, and Staff Physician in the Division of Dermatology at the Sunnybrook Health Science Center and Women's College Hospital. His clinical practice focuses on complex medical dermatology, and he runs subspecialty clinics in HS and cutaneous lymphomas at Women's College Hospital and Odette Cancer Center. He is a clinician researcher focusing on the study of comorbidities and patient outcomes in hidradenitis suppurativa and other autoimmune skin disorders. Dr. Goldberg is VP and Associate Dean of Graduate Medical Education and the General Surgeon at Mary Washington Healthcare, who has been treating HS patients for many years. She became interested in caring for HS patients when she saw the impact the disease has on patients' lives and felt that there were better surgical options that could be offered. She enjoys bringing together multidisciplinary teams to provide the best possible patient-centered care. And with that, I will now turn over to them to provide their excellent presentations. Thank you.
Hello, everyone. I'm delighted to be speaking today to an international group of HS patients. What I'm hoping to do in the coming 10 minutes, it will be impossible to cover every aspect about managing HS, but to highlight some of the things we have in common across different parts of the world, in addition to some of our unique experiences in Canada that might be useful in other jurisdictions. These are my conflicts of interest, and that might impact some of the medications and therapies I'll be covering today. I want to start with what we have in common. And I think over the last 7 to 8 years, through collaboration and meetings, international meetings, both in Europe, the European HS Foundation, and in North America, we have a common approach to the management of HS when it comes to the main principles of treatment, whether it's the medical therapies or procedural treatments and management of acute lesions, and how we combine those and where we start and how we move along in managing those patients. I do like to simplify things, and I like to work toward a common goal, which is achieving disease control. And when I think about that, among those treatment approaches, I like to think about the game changer. The game changers are the medications that really can help in turning things around for patients with severe disease. And those would be the systemic antibiotics and the biologic therapies. And then we have our adjunct medical therapies, where they can be quite helpful in milder cases and also as adjunct treatments for patients with more severe disease. And these would be our anti-androgens, some of our immunosuppressive therapies, and then other treatment modalities such as natural therapies with zinc supplement. HS, especially in the more severe cases, does require a multidisciplinary approach. And that is where we need a dermatologist is not going to be able to do that on their own. And we need to work with our colleagues in other specialties to provide patients with that supportive care. And depending on the patient situation, these could be their comorbidities, other diseases that they have. For patients who need wound care, we'll need a wound care experts to assess with the management of the patients, and then the patients who do require pain control. We will hear later on from Dr. Goldberg about the role of surgery, but it's something that is always on the mind of us in dermatology. So we think about medically optimizing patients for surgical intervention, and for patients with very severe disease, sometimes the other way around, where we optimize them to a degree, but then surgery comes in to optimize the patients further for their medical treatment to be effective. Another way of looking at this is thinking about the treatment foundations. And again, I think over the last 5 to 7 years, biologics are gaining more role in the treatment of more in moderate severe disease. We think about our antibiotic therapies in combination with biologic therapies, and then the surgery really goes hand in hand as an adjunct treatment. And then depending on the patient situation, whether we're using the anti-androgens or intralesional analog for acute flares, and then our immunosuppressive therapies / systemic steroids as an adjunct treatment in more severe disease that's not really being controlled with biologics and antibiotics. And in addition to that, although it's not here, natural therapies where it can be quite useful across the board, such as the zinc supplement. Moving from that into some of our experiences in Canada that I'm hoping will be useful for patients and physicians in other jurisdictions. I'm going to start with the biosimilars, which we are about 2 or 3 years ahead of the United States in the introduction of biosimilars. We're about 3 or 4 years behind Europe when it comes to the introduction of biosimilars. And for those who are not as familiar with the concept of biosimilars, so those are medications that are developed to mimic the originator biologic, and that is usually comes into account once the originator biologic have lost their exclusivity, which varies between 8 and 15 years from the time it was first introduced. There are a few differences between the originator drug and the biosimilars. So the development, the originator is developed from scratch. They have to establish that this is an effective and safe treatment for this disease, while biosimilars are really building on those findings to ensure that they develop a product that is similar to the originator drug. The manufacturing of the originator is much more complex, again, because they're starting from scratch. The advantage of the biosimilars is really they tend to be less expensive, which can help in terms of access for more patients. The efficacy and safety. So the originator, because again, it's a new concept, they need to demonstrate that through extensive clinical trials, while in the case of the biosimilars, they need to show through analytical analysis and non-clinical data initially that is very similar to the originator drug, and then some clinical studies, but it's not usually as extensive as the originator drug. And then in terms of access, because biosimilars tend to be associated with less cost, there's opportunity to increase access for more patients. So our experiences in Canada with biosimilars, I want to highlight a few things. So in Canada, we have multiple biosimilar companies. The last time I think we counted, we have 8 of them, which is overall is actually good in terms of providing more perks that our patients hopefully would benefit from. One of the initial concerns were are they going to provide a similar patient support program to what the originators do? And all of them, basically across the board here, they do have a very similar support programs to the originator drugs. And we noticed some potential benefits. So the lower cost, improved access. And we did see that in Canada because, especially for patients on public funding, it was much easier to have them covered with biosimilars to compare to the originator drug. Also, it was now standard that we have access to therapeutic drug monitoring, and I'm going to talk about that later a little bit later in the talk, where we can measure the drug levels and adjust based on that in terms of dose escalation, so increasing the dose for those patients who might need it. And then some of those programs actually, again, because of the multiple companies are trying to curve some interest or perks for our patients. So some of them, for example, provide nutritional counseling, which many of our patients, they find helpful. But there are still some gaps in the knowledge. We'd love to have more real-world data about the use of biosimilars, specifically NHS. And it's difficult to take data from one jurisdiction and apply to the other because it depends on which biosimilar was used and what are the factors that might have impacted those outcomes that are being measured. But to the most part, at least data from non-HS indications are reassuring. I can think of one patient who had basically hives related to a preservative in one of the biosimilars, and we just switched to a different biosimilar, and they did very well. I did talk briefly about therapeutic drug monitoring, and what's involved in that is, so we do have some data published previously showing that about 25% of HS patients develop anti-drug antibodies after approximately a year and a half or 18 months of follow-up. And when that happens, the medication stops working because their body is basically developing antibodies, breaking down the medication. Our own data shows that for patients who are not fully responding to the treatment, when we measured their drug levels, we found that about of those patients, 43% had subtherapeutic drug levels. So they have low levels of the medication. And those are the patients who might benefit from dose escalation. So we're increasing their dose from the standard 40 milligrams weekly to 80 milligrams. The other aspect I want to highlight is the hidradenitis comorbidities, which can be, which is important for two reasons. One, well, it needs to be screened for and identified early on, but it does provide an opportunity in terms of expanding treatment options. There are a lot of comorbidities associated with HS, including PCOS, depression, obesity, metabolic syndrome, psoriasis, pyoderma gangrenosum. But I want to specifically focus on the two important autoimmune diseases or inflammatory diseases, inflammatory bowel disease, IBD, or inflammatory arthritis. And the reason for that is it's important to distinguish between them and to identify the patients who might have more than one autoimmune or inflammatory disease, but they also provide opportunity in terms of accessing some of the treatments that might be approved for one of those diseases and potentially can benefit the other diseases. So in HS, among those three diseases, HS has less access to approved medications, but the other medications approved for IBD and arthritis, some of them are already being investigated in HS, and in real world, we know they can benefit some patients. So if a patient has both of those diseases, we collaborate with their other specialists to provide them with access to those medications. In terms of the inflammatory arthritis, so a meta-analysis of the different studies that were published showed that patients with HS have a threefold increase in the risk of inflammatory arthritis. And this is primary data from a study we're conducting where when we screened our patients, 84% of the patients reported that they have arthralgia or joint pains, and 25% of patients reported having morning stiffness in their hands lasting for more than 30 minutes, which is a quite specific marker for the presence of inflammatory arthritis. Another aspect about HS and HS comorbidities is for the patients who have extensive involvement in the perianal area, it is important to identify whether some of those sinuses are connected to the GI tract. And it is difficult to distinguish based on clinical examination, so thorough evaluation is needed. And typically the gold standard would be an MRI of the pelvic area with a fistula protocol. So a dye is used to see the extent of those fistulas and the openings within the GI tract if it's present. Why is that important? Because a study that was done by colorectal surgeons, screening more than 100 patients with perianal fistulas, only 6% of those patients actually have HS. And that's important because the treatment approach to something like this would be different from the treatment modalities that we use in HS. So typically for something like that, it's usually surgical intervention, although there's some medical treatments that gastroenterologists might use, but also surgical intervention seems to be the most effective, where those ceton wires are inserted, keeping those fistulas open so they're not blocked, resulting in further inflammation. And I think the association with HS is more common because we do have patients who, I would say it's certainly more than 6%, who have HS in other parts, but then they have perianal fistulas. And it's important we have strategies to address both conditions. Finally, I want to talk about diet and immunity. I think this is important to our patients, whether there's anything in diet that can be related to it. So Baker's yeast, which can be actually measured in terms of antibodies. It's called anti-Saccharomyces cerevisiae antibodies, are only present in less than 5% of healthy controls, but it is present in up to 70% of patients with Crohn's disease. And when it comes to HS patients, it's about 25% of HS patients can have those antibodies. The final thing I want to talk about is about the treatment pipeline. So the hope of the new developments, and we're glad to see that a lot of molecules are being investigated. I'm going to touch more about the phase 3 because those are the medications where we are basically, hopefully in the coming 2 years or so, if they're successful, they'll be available in the market. So secukinumab is an anti-IL-17, and their phase 3 studies are very promising for patients responding to the treatment, both by the end of the 16 weeks and up to 1 year after treatment. And the other interleukin-17 is called bimekizumab. And again, it's quite effective. Again, with the standard, we look at the high score 50, which is 50% reduction in lesion count. But now we're actually looking at 75% reduction in lesion count. And it's nice to see that we're aiming for better control of the disease with the newer treatments. And thank you very much. I will turn it on to Dr. Goldberg to cover the aspects of surgery in HS.
Good morning or good afternoon, depending on where you are right now. It's so nice to virtually see all of you, and I'm going to do my best to give a very brief overview of surgery in the next 10 minutes in a way that will give you some information so that you can ask questions and advocate for yourselves. So I'm a surgeon. I work at Mary Washington Healthcare in Fredericksburg, Virginia. It's about 45 minutes south of Washington, D.C., and I specialize in HS surgery. So today I'm going to talk about the role for HS in surgery, or excuse me, surgery in HS, types of surgical procedures, questions that you can ask when you are evaluated for surgery and make the decision whether or not to embark on that journey, and what you can do to help make surgery a success. I will be showing some pictures. All patients whose pictures are shown have given permission for me to show these. If you are concerned at all, please feel free to look away from the screen. But my hope is that these will be informative rather than upset you in any way. So the concept of surgery in HS has really evolved. And what I'm asking for you to do is keep a fresh mindset when you talk about surgery and talk about surgeons or talk to surgeons. In the past, surgery was almost viewed as a last resort type of technique. But the reality is that when used in combination with medical management, it can be incredibly effective at long-term management of disease. It's important to know that if you are referred from surgery or if you go to meet with a surgeon, this doesn't mean that everything else has failed. It's really, really important. More so, look at it in terms of, wow, this is another great treatment modality that we can use to give us hope and to help achieve our goals. So the next important piece to know is that not all surgeons understand HS. And not only do we in the HS world as providers need to educate them, but you all have a role in educating them as well. The reason is that the education that has existed for years and years in the surgical field is completely wrong. And we are working as a group to try to educate them. Because of that, it's really hard to vet a surgeon and understand whether or not they can meet your needs. So I wanted to arm you with a red flag. If you hear the term cure from them, we are going to cure your disease, or this is only a surgical disease, that should be a red flag where you want to pause and ask them some additional clarifying questions, because we know that this is a systemic disease and it's a multimodal approach to management. And we know that surgery is not a cure per se, although surgery can help manage the disease. The other piece is that surgery can mean a lot of different things. So when I talk to you about surgery and I use these terms and I show you pictures, my version of this may be very different to what other surgeons might discuss with you. So when you meet with a surgeon, it's important to have these conversations to really tease out what they're going to do, what the recovery is going to look like, what the goals are going to be, and so forth. And the other piece I want to impart on you is that there is space for surgery for everyone. And surgery can be very small, it can be much larger. So it's important to tease out. Everyone is a surgical candidate, and it's important to understand how these techniques can be used and applied to different people. Everyone's HS is completely different, and how it presents is completely different. So when you also talk to your friends or colleagues or people within the HS community, please know that the impact of surgery on one may be very different than the impact of surgery on another. Okay, so why do surgery for HS? This is the crux of successful surgical management. You have to define what your goals are. And the first thing I do when patients come to see me and say, "What is your goal of this visit?" or "What is your goal of surgery for HS?" And it might be pain, decreased pain. It might be decreased drainage, less infections. It might be improved quality of life with increased social and professional interactions. And another way to look at surgery for HS is whether or not we're operating for localized or more diffuse disease. And what I mean by that is, do you have disease that's limited to one area, or do you have disease in all areas of your body? That may change why we do surgery for HS and how we go about doing surgery for HS. So, for example, if it's limited to the armpits and there are things that we can do to remove it from the armpits, that might be different from if it's in all areas of the body and we're trying to pull out different areas that in a lesion or in a way where we address the lesion specifically so that one area may not flare as much, or it may not drain as much, or cause as much pain. So surgery can be successful if we set goals and expectations. There are 3 types of surgical procedures, and that's it. So when you go to speak with the physicians, this is a great framework to use to talk about what they're going to do in the different type of procedures. There's incision and drainage, deroofing, and excision of tissue, which can be smaller or wider. And for the purposes of this conversation, we're going to talk about wide excision. The reality is that all of these things do the same thing to some extent, with the exception of incision and drainage, and we'll get there. But deroofing and the wide excision remove either the actual tunnels down to the subcutaneous tissue or the roofs of the tunnels, and they remove the inflammatory gelatinous material inside, which is causing things to flare and flare and flare. A brief word about tools to do surgery. There's a lot of conversation about which tool is better and which tool is associated with less pain and so forth. And for example, the CO2 laser. The reality is that all of these things are tools. And the intent of these tools is to do the exact same thing, which I mentioned before, which is to remove or debulk that inflammatory tissue that's causing the flares and the pain. So the reality is different surgeons, different dermatologists have different tools available for them. For the most part, they're all equivocal, as long as the technique is done in a way that will remove all of that tissue. So let's go through each of these individually. Incision and drainage. Incision and drainage, it is a procedure. It is a surgery, so to speak, but the intent of incision and drainage is very different than the intent of the other procedures. Intent of incision and drainage is to essentially relieve pressure and relieve pain. And it's great for that. There's a lot of controversy in the HS world regarding whether or not incision or drainage should be done. Why? Well, a couple reasons. Number one is that it's not curative. And we know, again, that nothing is really curative per se, but in this situation, we know that the recurrence rate is nearly 100%. So why is that occurring? Well, we're opening it up, we're draining the fluid, but we're leaving that inflammatory material that's still present there. So we expect it to come back. So the way I use it is if a patient asks me to do it in the acute setting to relieve pressure and pain, and it's important to note that it can improve or worsen quality of pain. So why is this? Well, if you have a non-draining lesion and we open it up, there's a good chance it's not going to heal up completely. So now we've gone from having a closed wound that flares to an open wound that is just not going to heal. Moving on to deroofing, this is a fantastic tool. And what happens in the deroofing procedure is that there's a tunnel. Sometimes it's open, sometimes it's not open. And what we do is we try to open up the tunnel, take off the roof, almost like you're lifting the roof off of a house, and then remove all the gelatinous material inside, which is that inflammatory tissue causing the problem. And if you look over to the right hand of the screen and you look at the second picture down, you can see that open tunnel with all of the jelly inside. We remove that jelly and look how beautifully it closes. The other technique is the excision. And the difference between the deroofing and the excision is that whereas we open up the tunnel and we keep the kind of rind of the tunnel, so to speak, or the base of the tunnel, with wide excision, we're actually excising down to the fat. Now, or what we call fat subcutaneous tissue. If you look at this picture, it's scary. It's really scary. Interestingly enough, it's not very deep. In some people, it can be, but these heal up beautifully, and we're going to talk about that in just a second. So what does the healing process look like for wide excision? I'm going to pivot for 1 second and go back to the healing for the deroofing. The healing for the deroofing can be a bit similar, but it's not quite as deep. So it's typically a little bit faster depending on how it's done. But let's focus on the wide excision healing. So there are a number of different ways that we can heal these wounds. One is with primary closure, one is with a flap, and one is by secondary intention. So I'm going to talk about the primary closure. I'm not going to talk about the flaps for the purposes of this talk. I'm not a big fan of flaps. And the reason I'm not a big fan of flaps is because with the flaps, oftentimes, we know this is a systemic disease, and with all the changes associated with HS in the surrounding tissue, the tissue still has inflammation. So when you close it, there's a good chance that it can return or that you can have wound healing issues. And when that does happen with a flap, it can be a really devastating situation. That being said, I know many of you have had flaps and have success with that. So in the right situation, it can be great. And I encourage you to really have this discussion with your surgeon. All right, so primary closure. In surgery and historically in the field of surgery, we have been taught to close all of these wounds. And years of experience have taught me the challenges associated with this. And I'm going to ask you to look all the way over to the right-hand side of the picture. You can see a closed wound and some of the complications that can occur. Not all the time, but sometimes. So the tissue in general, we talked about the changes that are happening systemically through the body, which makes it difficult to heal. Oftentimes there can be infection and bacteria, and oftentimes the wound breakdown. If you do have a recurrence, you've already created this long cavity, so it will actually recur along the incision line and can be worse than how the disease was beforehand. The pro, of course, of this is that it's faster time to heal and there's not as intensive wound care. The con is that you have to keep, for example, your arm at their side, limit your mobility. You might be you're not able to be as active. And as I mentioned, there's a high risk of recurrence and breakdown. So I'm a big fan of secondary healing, or letting it heal from the inside out. And here's a picture of that. And what I want you to look at is the progression of the wound. The middle wound is so big, and over time it heals to a scar, a line of a scar, and everyone heals differently. Some people, the scar is much smaller. Some people, it's flatter. It typically takes about a year to know how a scar is going to look and how it's going to heal. The reason I like this is because the day after surgery, I want you moving your arm. I want you moving around. The wound care is really simple. And patients and people with HS have a great ability to heal. The way I do the wound care is it's just putting a dressing right on top and then some gauze and tape. For the first week or so, it can be a little overwhelming. And then after that, it gets very, very easy, especially in a lot of people who have HS, because you're so experienced with wound care. To heal a wound of this size, it can take anywhere between 2 to 4 months, give or take. Again, everybody is a bit different, but you can get back to your life as soon as you feel up for it. So I have some patients who within a couple of days are up and moving around and walking around with gauze on their arm. It just depends. Another option for the big wounds is to put something called a wound vac on there. It's a negative pressure suction device. It's fantastic. It has the same outcome as with the dressings that you put on. People like it because the wound care can be a bit less cumbersome. However, you are attached to a machine. It's noisy. It can be a little uncomfortable. It may speed healing, but not a significant enough amount for most people. I tend to use it for larger wounds if people don't have the help that they need for the wound care, or want to minimize the number of dressing changes. And then, of course, there's skin grafts. I've shied away from doing skin grafts for a number of different reasons, including the pain, as well as the fact that people who have diffuse HS throughout their entire body may not have a good area of skin to take to put back up. But I do them very, very rarely, but if asked to do that. Not all surgeries have to be big. And this is an example of a patient, and this is actually underneath the breast area, where they had lesions in all different areas. And instead of doing a big cut, what we did was we went in and de-roofed all of those different little lesions and look at the outcome when they healed. They had scarring, but the scarring is different than the scarring that occurred with HS, and they didn't have any disease or any pain. So just remember that the days of doing these big, long surgeries where you need to have a colostomy bag, if you have perianal disease, for example, you need to be in the hospital. Those are gone. Those are a thing of the past. In fact, all of my patients pretty much go home the same day for surgery. And if they have big areas, we do things in staged fashion over time. So when you go to meet with your doctor, these are great questions to ask. Here are my goals. Can you help me accomplish them? Will surgery be in the office or in the operating room? Will I be asleep? Will the wound be left opened or closed? And what type of wound care will I need? Will supplies be sent to my house? And do I have to do my own wound care, or will a nurse come to the house? And having a nurse come to the house these days every day is pretty tough. What will the pain be like? And that's a whole nother conversation, because pain is so different for everyone. But the goal is to reduce your pain to a level that's manageable in the postoperative period, knowing that it's going to get better day by day. Most patients are in so much pain even before surgery that they are willing to take this journey. How long will it take to heal? When will I return to work? Will it come back? And will I need more surgeries? And if I leave you with one message, my message to you is going to be, don't focus so much on whether or not it's going to come back to understand whether or not surgery will be a success for you. Focus on the things that you are looking for from a quality of life standpoint, because we know this is a systemic disease. And there are certain areas where I can tell you, depending on the technique we do and how we do it, it will come back. It's just, what can we do to mitigate this, and what can we do to better control it?
Thank you
And
so much, Dr. Alhusayen and Dr. Goldberg. And we will go over to some questions from the audience. We have one here. Are there particular sources that you recommend for researching medications, benefits, side effects, and clinical trial data, Dr. Alhusayen?
Yeah, I can refer to two excellent sites, the American HS Foundation and the Canadian HS Foundation. Both of them have very nice resources available. The Canadian HS Foundation also have an ebook, free ebook for patients. So I would refer the patients to those two sites for very useful and helpful information.
Okay, good. Thank you. The next one is for Dr. Goldberg. When people talk of skin grafts, there are two different depths in that, correct? Can you explain them real quick? The second part, I'm wondering, doesn't putting a skin graft over a wide excision with second intent then put hair follicles back where we just had removed them?
that's a great question. So Laura, thank you for your question. There are two depths. There's a split thickness skin graft and a full thickness skin graft. And we also need to, all of these go down essentially to the top layer of the skin. HS typically occurs more in the deeper layers, the dermal area of the skin. When I do skin grafts, I do use a split thickness, which is a thinner type of graft. When we do skin grafts, you cannot excise a wound and in the operating room at the same time put down the skin graft. We actually need to prepare the skin, the bed of tissue to receive and to take the skin graft. And the way we do that is by giving it some time to heal by secondary intention and heal from the inside out. So typically you would have a wide excision, then undergo some form of wound care, whether it's a wound vac therapy or that dressing that I spoke about, and then go back to the operating room for an additional procedure where they would take a piece of skin, oftentimes from your thigh or from your back, superficial, so we wouldn't necessarily we wouldn't have the hair follicles, and then put it overlying that good wound bed. So I hope that answers your question.
Then we have another one. How do we find the surgeons who want to work with patients with HS?
That is a really hard question. And I will tell you, it's very, very, very hard. You reach out to your peers. That's number one. Reach out to members of the HS Foundation and the providers within the HS community who know and trust people. There are not many of us. There are a lot of people who say they understand HS, but again, their knowledge base is a bit different because in the surgical field, we've been taught so many different things. So I think word of mouth goes a long way. A number of us do see patients from out of town and will help try to find you a local surgeon who understands and can provide the resources that you need, or arrange for remote-based care with an in-person consultation or virtual consultation, and that followed by surgery the next day, and then going home with the remaining of the care virtual. But it is very hard, and right now, other than through the HS foundations, we really don't have a good space for you. If you are calling a surgeon, when you call the office, I think it's reasonable to say, I have HS. Is this something that Dr. So-and-so is willing to care for? And have that honest conversation with them. If when you get into the office, they don't seem to understand it, they talk about a cure, they don't give you what you need, it's time to keep looking. And I think I speak on behalf of the HS Foundation. We would be happy to help guide you in any way we can.
I think we have time for one more if the answer is quick. Is surgery the only way to address a stage 3 flare area? can natural healing occur without surgery?
So I'm going to let I'll start answering the surgical part of that, and then I'm going to ask you to weigh in, Raed, about the medical part of things. Medicine has come a really long way in terms of its treatment. So when you're looking for if a person has stage 3, the best management is typically a combination of surgical and medical management. It doesn't mean that you have to have surgery. We just have to set expectations for what you're looking for. A lot of patients can be managed with medication, but everyone is different. So it's always good to work with both a surgeon and a dermatologist who can really optimize everything to help address your goals and your needs.
I'm just going to touch on the medical side of things. And yeah, I agree totally with Dr. Goldberg. So there are some medical interventions that we can use for the more severe cases. And going back to the game changers, so we can think on the most severe cases, a course of IV ertapenem antibiotic can be used for severe acute flares. Biologic therapies, we can modify those based on the previous response and previous treatments. And then we talk about short courses of prednisone or other immunosuppressive therapies that can also be used in those cases.
Thank you very much. I think that is actually the time we have for questions, even if there were a few more. We are now going to take a 10-minute break and then come back with Dr. Kimberly Kerseen for a session on the pain management. Thank you, everybody.